Welcome to this deep dive. Today, we're really getting into a topic that's just incredibly important right now in the U.S. Black maternal and infant health disparities.
Yeah, it's critical. And the material we're looking at today, it's a literature review done for the National Black Child Development Institute, NBCDI. It was actually put together for their Black Infant and Maternal Health Task Force.
Right. And our goal here, our mission for this deep dive, is to unpack that source material. We'll be looking at it through some really powerful lenses: anti-Black racism, intersectionality.
Afrofuturism, yeah. We want to pull out the most crucial insights,
Mhm.
the causes, the consequences, which are pretty stark, and importantly, what the source suggests as potential solutions.
And this is where it gets, well, just so striking. We spend a huge amount on healthcare in the U.S., like $4.9 trillion in 2023.
Astronomical.
That's about, what, $15,000 per person? But then you look at the outcomes. Our maternal mortality rate, it's way higher than many other comparable wealthy nations.
Infant mortality isn't great either, globally speaking.
Exactly. But the part that's truly heartbreaking, and I think really gets to the core of what we're discussing, is that the source points out over 80% of pregnancy-related deaths here are preventable.
Preventable. That word is key. It tells you right away, like you said, these aren't just unavoidable medical outcomes. The source is really clear. This points to systemic failures.
Uh-huh.
And that's what we're exploring. Why do these preventable tragedies hit Black families so disproportionately?
Okay, so let's start there. Let's try to grasp the sheer scale of this crisis. I mean, maternal and infant health disparities, they're undeniably a major public health issue.
Absolutely, a pressing one. And the data just consistently shows Black women and infants bearing the brunt of it. And again, the source emphasizes it's not down to individual medical issues primarily, it's these systemic problems.
So the source uses a specific indicator, a measurable one, to track this: low birth weight, or LBW.
Yeah, LBW,
Yeah.
defined as a baby born weighing less than 2,500 grams, so about 5.5 pounds.
And the numbers there are, well, they're pretty jarring.
They really are. For 2020, the LBW rate for Black infants was 13.8%.
13.8.
Compare that to, say, non-Hispanic white infants at 6.8%, Hispanic or Latino, 7.4%. The overall U.S. average was 8.2%.
So Black infants are basically twice as likely to be born at a low birth weight compared to white infants.
Pretty much, yeah. It's a huge gap.
And what really jumped out at me from the source material is that this gap exists regardless of the mother's education or income.
That's such a critical point. It pushes back against the idea that, just achieving a certain socioeconomic status buffers you from this risk if you're Black.
It suggests something bigger is at play.
Exactly. It steers us towards looking at those larger systemic factors. And dealing with LBW, it's not just about that initial weight. It has these long-term ripples. The source connects it to complex medical problems later on, developmental delays, even chronic conditions stretching into adulthood.
So reducing this disparity could literally change health trajectories over a lifetime.
Definitely. It can have a massive impact even on geographic health disparities across the country.
Okay, so if LBW is this critical sign, and it's not just explained by individual income or education, what is the root cause according to this source?
The source points squarely at anti-Black racism. It's something that's becoming much more widely recognized in public health, and this review confirms it. Racism itself is a fundamental social determinant of health.
And we need to be clear, we're not just talking about, individual biases here, are we?
No, not at all. The source is specific. It defines anti-Black racism as these particular forms of prejudice and discrimination aimed at Black people and communities, but crucially, they're embedded, baked into our social, political, institutional structures.
It's structural, yeah. I remember the source uses this phrase: it shapes everything from the community environment, access to care, education, jobs, creating an ecosystem of disadvantage.
That's the one. Ecosystem of disadvantage. It captures how pervasive it is.
How does the source kind of trace that out? Does it connect it to history?
Oh, absolutely. It draws a line directly from the history of slavery, unethical medical experimentation, forced sterilizations, all these historical traumas.
Things that feel like they were long ago, but maybe aren't so distant in their effect.
Exactly. The source argues there's a continuity. These aren't just footnotes in history books. They directly connect to present-day issues, like the high rates of LBW. It shows these problems have deep, deep roots in centuries of systemic oppression.
And then layered on top of that structural piece, there's the interpersonal experience, particularly in healthcare.
Right. Black birthing parents often describe encountering stereotypes, facing discrimination, just feeling the weight of institutionalized racism during their care.
There was a quote in the source about that.
Yes, it's powerful. Having to endure racial stereotypes, discrimination, and institutionalized racism has an effect on health above and beyond socioeconomic circumstances.
Above and beyond. So the experience itself is a health factor.
Precisely. That stress, that constant vigilance, it becomes an additional health burden. The source actually introduces the concept of racial trauma here.
Racial trauma.
Yeah, it's the emotional and psychological toll from dealing with racism, discrimination, microaggressions, stereotypes, barriers, all of it. The source identifies it as another social determinant impacting health and birth outcomes.
Wow. Okay. And that leads us to something really fascinating. The source brings up a biological pathway for how this chronic stress actually gets under the skin, the weathering hypothesis.
Yes, the weathering hypothesis, developed by Dr. Arlene Geronimus. It's a really important concept here. The basic idea is that chronic exposure to racism and the socioeconomic disadvantages that often go with it literally accelerates biological aging. It wears the body down fast.
It wears the body down. How do they measure that?
The source cites evidence looking at telomere length. Telomeres like protected caps on our chromosomes, and they naturally shorten as we age. The finding cited is that Black women's biological age, based on telomere length, is roughly 7.5 years older than their chronological age compared to white women.
7.5 years, biologically older.
That's what the research suggests. And a significant chunk of that difference is linked directly to stress and poverty.
That's profound.
It really is. And this accelerated aging, this weathering, helps explain why Black women face higher rates of pregnancy complications and mortality, even when you control for things like income or education level.
So it provides a direct biological link from that systemic racism we were talking about.
Exactly. To outcomes like preterm birth and low birth weight. The source even mentions studies finding that counties with higher levels of reported racial prejudice tend to have worse birth outcomes for Black infants.
So you've got this double whammy, addressing the immediate health needs during pregnancy, but also somehow addressing this cumulative biological toll of racism and trauma over a whole lifetime.
That's the immense challenge. You can't really fix the disparities without tackling those underlying foundational stressors.
Okay, so we've established anti-Black racism as a root cause, and we've seen how it can physically impact health through weathering. But the experience isn't monolithic, right? The source brings in another layer, intersectionality.
Yes, absolutely crucial. Dr. Kimberly Crenshaw's framework. It's essential for understanding the complexity here. Intersectionality helps us see how different forms of oppression, race, gender, class, maybe ability, sexual orientation, they don't just add up. They interact, they overlap, creating unique experiences and specific forms of disadvantage.
So for Black women and birthing people, it's not just racism or sexism, it's the combination.
It's the unique way those intersect. And other factors too, potentially. The source quotes Crenshaw directly on this.
What does it say?
Because the intersectional experience is greater than the sum of racism and sexism, any analysis that does not take intersectionality into account cannot sufficiently address the particular manner in which Black women are subordinated.
Greater than the sum, that really drives it home. It's not just additive.
Exactly. And the source gives this statistic that it stops you in your tracks. It perfectly illustrates this intersectional reality.
Okay, what is it?
It says, a college-educated Black mother is at 60% greater risk for maternal death than a white or Latina woman with less than a high school education.
Wait, say it again. A Black mother with a college degree?
Is at a 60% higher risk of dying from pregnancy-related causes than a white or Latina woman who didn't finish high school.
That completely demolishes the idea that education or class alone is the great equalizer, doesn't it?
Completely. It shows so clearly how race and gender intersect to create these vulnerabilities for Black women that socioeconomic status on its own just doesn't erase.
Wow. And the source also mentions economic status within the Black community, right? That middle class might not mean the same thing.
Yeah, it touches on how, due to historical factors like discrimination in jobs and housing and differences in generational wealth, middle-class Black women may actually have fewer financial resources or less of a safety net compared to middle-class white women. So even achieving that middle-class status might not confer the same health advantages.
Right. So this intersectional lens, it helps explain why these disparities persist across all socioeconomic levels.
Exactly. And why solutions that only look at one factor, like just income or just healthcare access, are bound to fall short.
Huh.
You have to see the whole interconnected picture.
Okay. So we've really dug into the roots of the problem, the mechanisms, the complexity. But the source doesn't just leave us there, which is good. It shifts towards, well, towards the future. It introduces Afrofuturism.
Yes, this is a really interesting and, I think, hopeful turn in the review. Afrofuturism is defined in the source as an intersection of imagination, technology, the future, and liberation.
Imagination, technology, future liberation. Okay.
It's this multidisciplinary way of thinking, blending aesthetics, history, social commentary, and like visionary thinking about what's possible.
And how does the source apply that to maternal and infant health? Seems like a leap initially.
It's framed as a truly transformative lens. The idea isn't just to tinker with the existing broken system. It's about using imagination, informed by history and culture, to completely reimagine care systems,
Reimagine them how?
to be deeply culturally responsive, community-centered, genuinely equitable, and really prioritizing Black autonomy, Black knowledge, and healing.
And NBCDI has a specific process for this.
They do. It's called the Afrofuturist Systems Design Process. And the source really emphasizes that this isn't about fixing the old problems. It's about designing and building completely new systems from the ground up.
Moving beyond just reacting to harm towards proactively creating something better.
Precisely. It's about envisioning what should exist. The key elements highlighted are thinking ahead, future forward, centering the community's own knowledge and needs, using that intersectional lens we just talked about, and really embracing radical imagination, daring to think differently.
And the foundation for all of this, according to the source.
Centering Black knowledge, experiences, and expertise. The argument is clear. Sustainable, effective solutions have to be driven by and grounded in the communities most affected.
Makes sense.
It also brings in the concept of Ubuntu, I am because we are. This idea of collective responsibility and mutual support as being fundamental to designing these new systems.
Okay, so that's the philosophy. What does it look like when you try to put it into practice? What are the tangible steps?
Well, it means a shift in focus. Instead of just documenting problems, deficits, disparities, you actively start designing those better alternatives. You challenge and dismantle the harmful stories often told about Black health. And you build systems that actively promote well-being. The vision described is pretty bold. An achievable future where every Black child thrives from birth.
Achievable future, that's key. So practical examples.
The source points towards culturally congruent care models. This could mean integrating traditional practices like the roles of midwives, doulas, community birth workers, alongside modern medical innovations. It's about respecting and valuing ancestral wisdom.
Blending the best of both worlds, maybe.
Kind of, yeah. And they mention group prenatal care models like centering,
Ah, yes, I've heard of those.
where groups of pregnant people get care together. It allows for shared experience, peer support, and really draws on the richness of everyone's backgrounds. The source puts it nicely. Prenatal care that does not also take into consideration the unique experiences of a woman person, their community, and the specificities of her cultural background cannot produce the highest quality outcome.
So care has to be personalized not just medically, but culturally and socially too.
Exactly. And the source is clear. This isn't just about what happens in the clinic. Policy changes are needed too. Policies that tackle those root causes, the structural racism, the cultural biases, not just tweaking healthcare access points.
Which brings us back, unfortunately, to the failures of the current system. The source details how discrimination, both structural and interpersonal, really plagues the existing healthcare setup.
Yeah, it revisits that point with more data. We mentioned it earlier, but it bears repeating. 1/3 of African Americans report experiencing discrimination in healthcare.
1 in 3.
And 1 in 5 say they've actually avoided seeking care because they were worried about facing discrimination.
That's a direct barrier to health right there. Fear.
A huge one. And the source also connects the dismissal of Black women's own knowledge, their perspectives, expertise, and lived experiences during prenatal visits, directly to delays in getting that care.
Yeah.
If you feel unheard, disrespected, why would you rush back?
It erodes trust.
Completely. And then there are factors outside the clinic walls. The source mentions how environmental stressors like heavy police presence in neighborhoods or concentrated poverty add another layer of risk.
How so?
It cites research linking areas with high levels of police contact to higher risks of preterm birth, specifically for U.S.-born Black individuals. It's the environment adding stress.
So it's the whole context, not just the doctor's office.
Right. And while the source acknowledges the incredible strength of family and community support networks and Black communities' vital lifelines, it stresses that these networks cannot and should not be expected to compensate for fundamental system failures.
They're coping mechanisms, not solutions.
Exactly. They can't bear that burden alone. Systemic change is required.
So, pulling it all together, what's the path forward that the source outlines? It sounds like it has to attack the problem from multiple angles.
It absolutely does. It's multi-pronged. You need to improve healthcare quality itself, tackle bias, implicit and explicit within medicine.
Okay.
You need equitable policies way beyond healthcare in housing, education, employment, the justice system, things that create fair opportunities and reduce those environmental stressors.
Addressing the social determinants.
Yes. And crucially, the source calls for comprehensive solutions that specifically target structural racism at every level. It has to be intentional and system-wide.
And this is really where the organization behind the source, NBCDI, comes in. Their work is focused on this.
Yes, their commitment is to dismantling these inequitable systems. And this literature review was commissioned by their Black Infant and Maternal Health Task Force, the BIMHTF.
Right. What's the specific job of that task force?
Their goal is to conduct a major nationwide study focused exclusively on uncovering the sort of unknown comorbidities and the ecological, environmental factors that contribute specifically to high LBW rates among Black infants.
Really drilling down into the specifics for this population.
Exactly. And importantly, reflecting that Afrofuturist approach, the study is designed to center the lived experiences of Black women, birthing people, and their partners.
So it's not just numbers, it's people's actual stories and contexts.
Yes, it aims to understand their realities.
Yeah.
And it also wants to identify community assets, strengths, protective factors, what's already working well within communities, not just focus on the deficits.
That's a positive framing.
It is.
Yeah.
And the idea is that this multidisciplinary team will generate findings that can actually guide interventions at the federal, state, local, even community levels, making that clear connection between what happens during pregnancy, the mother's health and experiences, and the baby's birth weight outcome.
And ultimately, NDCDI plans to use all this to push for real policy changes.
That's the goal, to develop actionable policy solutions for genuine system reform, moving towards that vision of truly equitable systems.
Okay, so wrapping up this deep dive then, the core message from this source seems incredibly clear. Black maternal and infant health disparities are a profound crisis.
Undeniably.
Rooted deeply in structural anti-Black racism and made even more complex by these intersecting oppressions like sexism and classism.
Absolutely. And the solutions, as the source frames them, can't just be small tweaks. It requires a willingness to dismantle what's not working.
Which is a lot.
Which is a lot, yes.
Yeah.
And having the courage, the imagination, really, to build new systems. Systems truly centered on Black liberation, healing, and autonomy.
And those frameworks we discussed, anti-Black racism, for really understanding the problem's foundation.
Intersectionality for grasping all its complex layers.
And Afrofuturism for providing that positive visionary path forward.
They seem like essential tools, yeah. For anyone trying to engage with this issue seriously, they give you both the diagnosis and potentially a roadmap for reimagining.
So, to leave you, the listener, with something to think about, drawing from those themes in the source, especially around Afrofuturism and Ubuntu, consider this idea of communal imagining as a real tool for change.
Communal imagining.
Yeah. How can we, collectively bringing together all our different experiences, our knowledge, maybe even some radical imagination, how can we reimagine and start building systems, not just in healthcare, but anywhere? Systems that go beyond just fixing the damage from past and present harm.
Systems that actually foster liberation, health, thriving.
Exactly. For everyone, but especially for those communities who've been most harmed by inequity, maybe think about what's one small step you could take, or even just one conversation you could start to be part of that reimagining process in your own world.